Thank you very much, and thank you so much to the organizing committee for inviting me. It's wonderful to be here in Hanoi, and last year we were in Ho Chi Minh City, so I met some of you already in similar situations. We're talking trauma. Trauma is affecting so many people all over the world, and it's important that we have knowledge of how to manage this. And we have learned a lot in history since we started. I am 76 years old, and it's 52 years since I graduated from dental school. And I graduated from Karolinska Institute in Stockholm, both the undergraduate years and the graduate years. I wrote my PhD thesis in Karolinska Institute and stayed there and worked as a maxillofacial surgeon in Sweden for many years. At the end of my career, I was asked to come to Kuwait to build a dental school together with colleagues, Kuwaiti colleagues and colleagues from all over the world. Among them, Professor Andersson, I met there, and we worked close together for many years in Kuwait. After returning back to Sweden, I'm connected now to Malmö University, which is very close to where I live, where I'm a senior professor. But as a young student and young graduate in dentistry, I have been so lucky because I have been fortunate to meet two huge giants in medicine and dentistry. We say now and then in our development that we are standing on the shoulders of huge giants, and I have really been standing on the shoulders of two huge giants. One is Professor Per-Ingvar Brånemark in Sweden. He's called the father of osseointegration and implants, and you have heard his name. And I belong to the first generation implant surgeons. So all people at that time, in the 80s and 90s, came to Sweden to learn about implants, about how these titanium screws integrated in the bone. And we trained a lot of surgeons from all over the world. So I was so lucky to have this mentor and having learned so much from him. So implant has been part of my life. And in my lecture tomorrow, I will talk about implants in a historical perspective, and also tell you when we should not place implants, because that's maybe the most important knowledge for all of us, to know when implants can be used and when implants should not be used and what alternatives we have. The other huge giant was in my life was Dr. Jens Andreasen in Copenhagen University. You have heard his name, of course, and he's called the father of dental traumatology. And he taught me all about tissue healing, and especially tissue healing after trauma. And I was lucky to, immediately after my undergraduate years, meet him, and he stimulated me to go into research, and we worked together in many research projects together. What have I done more? As mentioned, I was editor-in-chief during 9 years for the scientific journal Dental Traumatology. And it was the honor of my life when Jens Andreasen asked me to be co-editor of this famous textbook, also called the Trauma Bible, which is now out in its 5th edition. I've also been editor of maxillofacial surgery textbook, and I have made sure that the chapters on dental traumatology are good, which is unusual for textbooks in maxillofacial surgery. This has come out in the 2nd edition very recently. This happens all the time, all over the world. And this is what I faced when I came out as a young surgeon. The problem at that time was that we did not know very much about healing. We didn't know how healing took place. Sometimes we tried to put back the teeth. Sometimes they just extracted the teeth. And this was a really problematic cases because we didn't understand what was going on underneath the surface. We saw in these replanted teeth that we had root resorption, but we didn't understand what it was. This was in the 70s, and there had been no research on histology on this complication. We saw it on radiographs, and as you see from these radiographs from the 70s, they waited until they saw the root resorption until they extirpated the pulp. So, and then it's too late. You all know that a case like this with a closed apex, replanted tooth, we should always get rid of the pulp because we have no chance of revascularization in these cases. But at that time, we acted only when we saw the root resorption. So we have learned a lot from the research we have carried out over the years. But in the 70s, we didn't understand this. And we did not understand what this was. This is a case of ankylosis and infraposition, and you are familiar with this, and I will talk more about that in my lecture this afternoon, more in detail. Why do we get ankylosis, and what happens, and what should we do? We have methods now to manage such situations. Even if we cannot stop the progressive root resorption, we can still act in the correct way for tissue preservation. And in my lecture tomorrow, I will talk about that. Or late today, I should say it is. Okay, but at that time, in the 70s, when I was a young surgeon, we didn't know what we saw on the radiographs. Because we have only radiographs and we have the clinical pictures, but we didn't know on the cellular level what was going on. And this, as you know, with the replantation, you can get either normal healing, if the conditions are good, or you see a lot of complications like this. And in my lectures today, we will talk a lot about this, to give you a clear picture of what we can do today and what we did before. But in the old days, this was how trauma cases ended up, with extraction and removable partial dentures. But today, we have possibilities to treat cases like this. We know about the healing and what to do, so we can turn such a case into a completely different situation. So a few figures about tooth avulsion. You see it's a rare injury, but it's maybe the most serious injury that you can have. It's a few percent of all dental injuries, and dental injuries are so frequently occurring, so common. And although this is a rare injury, it's maybe the most severe injury. You see it in maxillary central incisors, and that is the area where we call the aesthetic zone. So what happens here is very important for the patient from an aesthetic point of view. It's also an area very much prone to trauma. It's most frequent in young patients, in children, but we also see it in the adults. And it's more frequent in boys than girls. And the main etiologic factors are sports, different kinds of games, play. Bicycle injuries are common causes of this. And also in more adult situations, people fight, and you see knocked out teeth. Let's repeat a little bit about the tissues. When the tooth is knocked out, its vascular supply, it's immediately interrupted. So the pulp inside this tissue, let's see if we have a laser pointer here, no? So the pulp has no vascularization. It's not supported by any blood. And that means that it takes only one bacteria to come into the pulp, and the bacteria has the most wonderful substrate for growing and multiplying, and we have no defense cells there who can reach the pulp. The injury is usually a tearing, crushing, or scraping of the periodontal thin tissue. And we can also see evaporation injury when it's dried out and the cells will die on its surface. The periodontal membrane is a thin cell layer, and there's a high risk of destruction of the cells. And the pulp, without vascular supply, we have an infarction of the pulp first. If bacteria comes in there, we will have a high risk of infection of the necrotic tissue. And the interesting thing with this is that the prognosis of a knocked out tooth and a replanted tooth is decided at the place of accident. It's not during the first days, it's actually during the first hour that you see the prognosis is decided. And we know that, known for many years, that it's the condition of the cells of the periodontal ligament which is the most critical factor for the prognosis. And we have always known that we should minimize the extra-alveolar time. We knew that already in the 70s and 80s. And we have known that we should put the tooth back as soon as possible. But now, from an historical perspective, that's an advantage when you grow old, that you remember how you did in the 70s, 80s, 90s, and so on. So you have seen the development over the years, and that's what I'm trying to convey to you. What did we do in the old days, and what can we do today? But already at that time, we knew that we should minimize the extra-alveolar time and replant the tooth as soon as possible. So where are we today? That's my task today to explain to you. And when I'm talking about dental trauma, I must mention again Jens Ove Andreasen in Copenhagen. He was a very wise man. He realized that if we're going to develop this and learn more, we have to register these injuries. So he took care of all the dental injuries in Copenhagen. He took standardized radiographs with film holders so he could reproduce the same angles when the patient came back. He took photographs and radiographs, and he followed these from the 60s. And this registration is still ongoing in Copenhagen. According to his standard, we are still registering all trauma cases. But you cannot tell very much from radiographs. You don't see any cells on radiographs. And the clinical pictures, you don't know what's going on underneath the surface. So the big step in development was when Jens Andreasen took the initiative and asked Copenhagen Serum Institute if he could use monkeys to study replanted teeth. At that time, we manufactured vaccine by taking the kidneys from the monkeys. So every week, 8 to 10 monkeys were killed in Copenhagen Serum Institute and to make a vaccine. So Jens Andreasen, he asked if he could, just a few weeks before the monkeys were killed, if he could give anesthesia to the monkeys and extract the teeth and treat them in different way and then replant the teeth. It's a wonderful model to learn about tooth avulsion and replantation. And that's the big step for research in dental traumatology that moved all our knowledge to where we are today. At that time, I worked in Stockholm at the Karolinska Institute. So when Jens Andreasen got the permission to work on monkeys, we asked if we also in Stockholm could do the same. And for the first time, we had a chance to extract teeth, put them back after different storage media, after different treatment, and we could go in and look at the histology. And this is a very intensive period in replantation research happening in the end of 70s, beginning of 80s. And we systematically in Stockholm and in Copenhagen studied a lot of factors. And if you read here, you see all the factors I have listed that we, during the end of 70s, 80s, started to look into. A lot of theses were produced, a lot of articles published around this. We asked questions and formulated research projects. And this is what we, during a period of 10, 15 years, carried out. I don't go through every factor here, but as you see, it's a lot of different things we study. I give you a few examples of that. This is a study in Stockholm we did in 1983. We wanted to see, look into the evaporation of the periodontal ligament. When a tooth is out, would it be possible to wrap it in plastic foil, we asked ourselves, because that's how we treat food in the evening. When we go to bed, we wrap our food into plastic foil, and if we prevent the evaporation, we can use this food the next day. So by wrapping a tooth in plastic foil, we could really prevent the tooth from drying. And then we went into histology with such teeth, replanted them, and look what happened here. This tooth was without root resorption, without ankylosis, and we see a normal healing of such teeth. That's a published study from 1983, and you see the plastic foil is as good as immediately replanted teeth. So the prevention of evaporation was very important. This is, of course, difficult to go out to the public, but as a principle, as an experimental research principle, we have shown that the evaporation, the drying out of the tooth is a very important factor. So then people started, shall we put the teeth in water? What about storage in water? At that time, we were doing cell studies, and this is a cell fibroblast stored in tap water for 60 minutes. And that will not save the cell. These cells will die immediately. The membrane is rupturing because of the osmolality difference between the inside and outside of the cells. So tap water was not the solution for such teeth. And we studied a lot of materials. This is a fibroblast stored in eagle cell medium. That is a cell cultivation medium. So this, remember this appearance as a healthy fibroblast. And then this is storage in physiologic saline, which is good osmolality, 60 minutes. That can also be possible, we learned. We tried saliva. This is storage in saliva, 60 minutes. And they look quite healthy, and we can also see bacteria here from the saliva. Can be an important factor. But this was very surprising for us. This is a fibroblast stored in milk for 3 hours, and it looks completely normal, because milk has the same composition as tissue fluid from an osmolality point of view, and this resulted in that we went out to the public. We went out and asked them to, if you cannot put the tooth back, put it in milk and go to the dentist. What this is about is that the extra and intracellular osmolality should ideally be the same. It's not about wet or dry, it's about the osmolality, to have a solution with a good osmolality. And we did replantation on the monkeys. You can see these are black and white pictures. Nowadays you publish in color, but it shows that we did this already back in the end of 70s, beginning of 80s. To the left you see replanted tooth in milk without any ankylosis or any distractions. To the right, we see a saliva, tooth stored in saliva for 6 hours, and the majority of this periodontal ligament seems to be normal, but you have also ankylosis. So saliva was not as good as milk in our experimental replantation studies. So we continued during these years to define the important factors, and you find today a lot of publications in each of these areas, thanks to this monkey experimental studies. This is not possible to do today, because today we manufacture vaccine in another way, so we cannot have access to monkeys in the same way as we had in the end of 70s and 80s. And all these publications resulted in our knowledge base for replantation and dental traumatology. And Professor Paul has already mentioned the books that were published around this. Recently, we have also, and Professor Paul mentioned that the Dental Trauma Guide is an interactive tool where you can go in and connect yourself to the database and put in the data of your patient and get step-by-step instructions how to diagnose and manage this. And I will talk more about that. And we have also arranged so you can get a code to the Dental Trauma Guide and have free access for that for the rest of this year. I will come back to that. So our knowledge base has increased, and we have helpful tools. So from talking about wet versus dry, we found different storage media increased the possibility of being successful. And we could, with different storage media, keep the cells alive for 1 hour at least. And this is where we were in the mid-80s knowledge-wise. This is the tooth in milk for 6 hours as a result of this experimental period. And milk became the recommendation all over the world, actually. It started in Sweden and in Scandinavia. Nowadays, this milk is distributed all over the world out to the public. So usually close to the accident, you can find milk if you knock on the door. If you don't have milk beside you, you can usually get access of it. And it has saved a lot of teeth, knocked out teeth. So this is probably the most important member of the trauma teeth, the trauma team. So which storage medium should be used? There are so many recommendations, so much laboratory experiments going on. So I will come back soon to what should we use. This is what they tried to do in Germany. They use the cell culture medium that you have in the laboratory. The problem here is that we have expiry dates, so we have to change these if you have them in ambulances and so on. But it seems to work in an organized state like Germany. They have these in the sports situation and also in ambulances. The problem is that it's not available always at the place of accident. And we have seen a number of publications on storage media, saliva, milk, physiologic saline, Hank's balanced salt solution is also ideal medium. And you see a lot of things here. But you have to remember one thing. You read on the lowest line there, the coconut water. It functions very well. But we don't have coconuts in Sweden, so you cannot recommend anything for the whole world. You have to locally adapt. And I'm so happy that you here in Vietnam have research, and we will hear that report soon, about egg albumin, egg white. You even have egg in the coffee, so you must have a lot of egg whites left. So the most important is that you adapt it locally to what people use. If you're in Sri Lanka, you can certainly recommend it coconut water, but not in Sweden. But understand it's all about the osmolality. And we will soon listen to our colleague here who will talk about egg white. And I am looking forward to listen to that. Excellent. So where do we go from here? From this cell cultivation period in the laboratories, we have learned a lot and increased our knowledge. But we must remember that what we have to do after the laboratories is to go to clinical long-term studies, to follow patients who have had teeth replanted. So we follow these patients over a long time and verify or reject the findings from the monkeys. And that is where we are now. We are moving from in vitro in cell studies in the 70s and 80s via the vivo replantation studies in monkeys in the 80s and 90s. And now we are in the stage where we try to start long-term clinical follow-up studies. So where is the scientific evidence today? We are quite low because we have based our knowledge on animal studies, and we have case control studies, some cohort studies, but it's difficult in traumatology for ethical reasons to do randomization and have different control groups and so on. I cannot tell the mother that we would like to have your son in a clinical study. We have a lottery if he becomes the experimental group or not. That's not ethical. So we have to go together instead and register all our avulsed teeth and replanted teeth and follow them up for a long period. That's the way to do, because we cannot, for ethical reason, randomize from the emergency situation. So as a summary, the prognosis is decided at the place of accident, and we have learned very much to understand what is going on underneath the surface. Now I will test you. We have a party. You have a telephone call to your clinic. We have a party celebrating our son's birthday, and one of the children has knocked out a tooth. What shall we do? This is what happens to you. You will have such telephone calls to your clinic or to you as a private person. So let me hear. What is the first thing you answer? Any suggestion? Hand up. Yeah, I can summarize. The most important question to them is, which birthday did you celebrate? Because we do not replant primary teeth. I have been in this situation during the night having this question and started almost advise them to replant teeth. But if it's a primary tooth, you should not carry out any replantation. That's important to remember, the age of the child, and try to find out through the telephone if it's a primary tooth or not. But then you give the advice to what? To do what? We try to encourage people to replant the tooth themselves, and most likely they will succeed. They don't turn it 180 degrees. I've seen it sometimes, but it's usually they manage to get them back by themselves in the correct position. Now we have the guidelines, the International Association of Dental Traumatology guidelines, And this is an expert group getting together, giving recommendations what to do. And they have, of course, also looked into tooth avulsion and replantation. And they have summarized this, and I encourage you to go to the IDT website, idtdentaltrauma.org, and you will find the guidelines. This is the guidelines for replantation, avulsion of permanent teeth. And you recognized Professor Abbott was part of that team, and then it's researchers and clinicians from all over the world. It's not always evidence-based, but it's an expert group telling you what we recommend to do. And if you go to these web pages, you will find this. And what we recommend is to keep the patient calm, find the permanent tooth and pick it up by the crown. And we describe it as the white part and so on. And you can go in yourself and read. If the tooth is dirty, you can rinse it in a medium or underwater. It's not dangerous for the cells if you rinse it. It's the long-term storage that kills the cells. But it's important to encourage the patient to put back the tooth immediately at the emergency site. And once they have managed with that, they should go to a dentist or emergency clinic where they can take care of the rest of the treatment. And if replantation is not possible, they should place it in a storage medium. This is what the guidelines say. And they recommend different things, such as milk, saliva, and saline, suitable, and other medium. And the tooth can then be brought to the patient, brought with the patient to the emergency clinic, and see a dentist immediately. So you must have emergency services working if this happens outside office hours. So I recommend you to two web pages that are important. The IDT guidelines, there you can read the articles, the text, and find all the information from these groups, these expert groups, what they recommend and how to do it and so on. This is an important web page, the idtdentaltrauma.org. And another very important web page is the Dental Trauma Guide. And that is what happened when the internet came. Dr. Andersson saw the possibility to connect the database in Copenhagen to any dentists in the world, wherever you are, and you are in Amazonas jungle or in the middle of Africa, you can connect through internet. And have you been into Dental Trauma Guide webpage, you immediately get some questions that you answer, and you can easily make, with the help of this interactive program, make the diagnosis, and you get information on how to manage this. So this is a very important web page. And as I mentioned, I will give you free access to this tool for the rest of this year. So the prognosis is decided very much what is carried out at the place of accident. In the clinic later, you have to make a differential diagnosis. It could be a fracture, a root fracture down there. It doesn't have to be a knocked out tooth. If you see a situation like this, you have to take radiographs and verify that this is an avulsed tooth. So you do an ordinary clinical inspection and radiographic examination. And how do we treat this? Well, the history taking is the most important. To interview the patient. And Professor Abbott mentioned about how to do this. This is the key to successful treatment. And what you should ask yourself is, in which condition are the PDL cells? You must judge if it's a dried out periodontal ligament or if they replanted the tooth within 5 minutes. It's a big difference, the healing conditions there in these two situations. When I talk about this, I use the traffic light and the traffic signals, red, blue, red, yellow, and green. And if we talk about the cells now, you have the patient in front of you. The patient is telling you information about the knocked out tooth. And you ask yourself, are these periodontal ligament cells less viable or necrotic? That is, have they been dried out for more than 1 hour? Then they are most likely necrotic. Or do we have, as in the green situation, immediately replanted teeth? The mother tells you that we put back the tooth immediately into its position. And it's a big difference how the expected healing will be in those different situations. The yellow color, these are the ones who are not completely dried out for an hour, but we know we have compromised PDL cells. These are typically the storage media that are here in the middle, and this is how we recommend this. And if you have this picture in your mind when you're meeting these patients, it will be easier to treat replanted teeth and assess the prognosis. So let's look at the green light first, the viable cells. We have a short extra alveolar time and the tooth is back within minutes. And the cells in those situations are in good condition and the prognosis is very good. And this is an important information for you when you call the patient back. It's a favorable prognosis, favorable long-term prognosis, and we have a viable periodontal ligament in this replantation situation. But we still have to follow up this and see. But it's a favorable result. We do this, so we only do the splinting in a case like this. And you use flexible splints. It's important for periodontal ligament healing that the tooth is moving. You should not have a rigid splint. And Professor Yen will talk about how to make ideal splint, because his recent research have shown the materials, the best materials, and how to do this. We splint this for up to 2 weeks, and not more than that. And it can be done in different ways. The most important is you have these principles. And Dr. Hien will talk more about how to manufacture a good splint. You can do it in many, many ways, but there is indications now that with the fiberglass that Dr. Jan will present in his lecture, that we can reach even further. The pulp, after replantation, as I mentioned, we have lost the vascular supply. We should by all means avoid infection. It takes only one bacteria to come in there, and the whole thing will explode. The bacteria have the most wonderful substrate, so they can multiply and grow there. So don't let the bacteria come in there. We should avoid infection and promote revascularization. That is the thinking we should have. If it will be an infection in the pulp, we will see a situation like this. These are from our experimental studies in the monkeys. You see an infected pulp there in the middle, and then you see the dentinal canals, and you can see the toxins are leaking out through the dentinal tubules, and you see clasts. The body is defending itself by directing clasts to go there and resorb. And this is infection-related resorption, inflammatory resorption. This is the mechanism behind this, and it's always bacteria behind this. And the tooth will be resorbed, and the resorption starts. And we understand these mechanisms, and we can avoid this now. In the old days, I told you, in the 70s, we waited for resorption to come. But today, we are proactive and go in. If the tooth has a closed apex, we go in and do the pulp removal within the first weeks. And with the open apex, revascularization is possible, as Professor Monti mentioned. Observe and keep the patient under control. We will hear more about the pulp later on. So in the pyramid of evidence, we have since the 70s and 80s moved our knowledge up in the pyramid, and now we're trying to create materials where we can, large materials where we can follow patients for a long time. So we are moving up in a higher quality of the evidence. I will show you some studies we have carried out in Copenhagen. We studied groups of teeth that have been replanted under different conditions. We have studied prompt replantation within 5 minutes. We have a group of delayed replantation after storage in saliva. We have so many teeth now that were replanted after saliva storage. We have it from Copenhagen, so we have looked into that. And we have also looked into delayed replantation after long-term dry storage. And these are human studies, clinical studies, which is very important to move in that direction. Let's look at the prompt replantation. These are data from patients with replanted permanent avulsed teeth. They were selected from the comprehensive dental trauma database in Copenhagen. And some of them have been followed up as long as 23 years. In total, 145 teeth. Immediately replanted teeth, 36. Group 2, 61 teeth stored in different media. And teeth stored dry before replantation, more than 60-minute dry. So these are the groups we have been looking on. And we saw that immediately replanted teeth, the risk of ankylosis was lower than if they were stored dry or in different media. Immediately replanted teeth, the risk of ankylosis was 17%, whereas if they have been stored dry more than 1 hour, it's 85%, 86%. So, and we also saw that immediate replantation was considerably better. So why don't we see 100% ankylosis in the 60-minute dried out teeth? We were surprised of that. We could not explain that. Some teeth healed even after being stored dry for more than 1 hour. They healed with normal periodontal ligament. And mature teeth showed a higher risk of ankylosis than immature teeth, which may be because in immature teeth you have a thicker periodontal membrane that is not dried out so quickly. I summarize the 3 groups with dry storage more than 30 minutes. That's the blue color. You have a high risk of ankylosis. You have a high risk of ankylosis, 85%. Whereas the immediate replanted teeth, we ended up around 20%, less than 20% risk of ankylosis. And then the different physiologic media, they fell in between there, and we saw significant differences between these groups. So now we have moved from experimental studies to long-term clinical studies, and that's where all research must aim, from experiments to clinical follow-up. And these have recently been published in 2023. So, for the prompt replantation, quick replanted teeth, we could conclude that we should continue to encourage avulsed permanent teeth to be replanted immediately, if possible, or as soon as possible. That's the first thing we should tell the patient. Try to put it back. But we have the storage is still a good alternative, although somewhat higher risk of ankylosis is expected. But we can manage ankylosis today. I will talk about that this afternoon. We understand these processes, so we can, although we cannot treat ankylosis, we can manage such teeth also and do the best for the preservation of tissues. So, what about the group with the storage media? We looked at the clinical material. We looked at teeth that had been stored in saliva, and no such study had been carried out at that time. We had seen in the monkey experiments, I told you, that both milk and saliva, we could see a lot of normal periodontal ligament. I showed you from the histological slides from that time. And it seemed from these studies that milk seemed to be a little better, more normal periodontal ligament than saliva group. So it was interesting to look clinically into this in the long-term follow-up study. And we looked at delayed replantation after storage in saliva. We published this a few years back in 2021. And now we have moved from experimental studies to the patients, and it seems to work. Around 50–60% is what we expect the risk of ankylosis to be if you store it in saliva. But this is a golden opportunity to save teeth and save cells, but all are not being free of ankylosis. We saw also that immature teeth had a lower risk of ankylosis than the mature teeth. And this is how we have to continue. Register your patients, follow up, and we can pool patients into large materials and look into different storage media. We are now starting a study in Scandinavia on milk as a storage media to see if that also functions, and it seems to do. So now we have verified also in humans that saliva is a good temporary storage medium. And this is how we must carry out our research. Ask a question, go in long-term follow-up study, aiming at first experimental animals and then to humans to verify or reject the findings that we saw in the animals. Some cases, this is a 6-year-old boy who had his incisors avulsed, and the mother had put them back in the mouth. And so they were stored in saliva for 150 minutes. And you see the follow-up over the years here. This is 20 years follow-up here. No signs of root resorption, no ankylotic sound. And these were only stored in saliva. So remember, saliva is available all the time in the patient's mouth. So don't forget that storage medium. Don't put the avulsed tooth in the pocket and go buy milk. Saliva you have in the mouth, and that's a good storage medium. So we should encourage temperate storage in saliva if we cannot replant the tooth. And we should also go into looking into the other storage media in clinical materials, such as milk, saline, and these should be evaluated in long-term clinical studies so we can see what happens to such replanted teeth. And different systematic review have shown the same. Milk seems to extend the periodontal ligament cell viability. But we have to go on with other storage media also in clinical studies. So if you have dried out completely the red signal here, we must expect ankylosis. There's a high risk for ankylosis here. So we expect that ankylosis will come, but we should not give up. Because we saw a few percent of these will still heal with normal periodontal ligament. We have discussed this, and maybe it has to do with the humidity in the air. If you have a humid place with a lot of humidity the day the tooth is knocked out, of course these cells will dry out. It will take longer time to do. Maybe that's the reason. We don't know. You know that the delayed replantation has a poor long-term prognosis, and the possible outcome will be ankylosis. So we should look for that in the follow-up. But we know also that we can manage situations with ankylosis, and that is my next lecture, we will talk about ankylosis more. The clinical signs is hypercussion, sound, lack of mobility, and the infraposition. But we can manage this today, and we'll talk more about that in this afternoon. We are not afraid of ankylosis any longer. In the old days, we cut out these teeth, we removed them, drilling them out. We don't do that because we can manage. It's a wonderful bone preservation material because this will be replaced by bone, and we can take advantage of that. But these are tough situations when you see infraposition, but don't extract such teeth because then the bone will collapse. I will show you this afternoon what we do today. So, we looked at the dried out teeth, and I showed you a similar picture before from that study. And I go quick through this. We had these other groups, different lengths of dry time, 400 teeth in different groups. And here we have the final results. We looked at the survival without ankylosis, and we saw that the shorter time, the better prognosis without ankylosis. But even in the dry storage, we did not have always ankylosis. We had some teeth that did not go into ankylosis, although they had been dried for 1 hour. Here is an example of that. 75 minutes dry storage, a replanted tooth, and followed up for many, many years, 5 years follow-up, and no signs of ankylosis, no signs of replacement resorption. So remember, there are teeth or humid days or whatever it is that can be replanted without ankylosis, just to remind you of this. So this is what happens when you follow up your patients over a long, long time. You will find surprising findings like this. So, if you go back 15, 20 years, there were recommendations that you should remove the periodontal ligament. You remember? Scrape it away, because this tooth has been out 30 minutes. But don't do that. These have been out even 60 minutes or more. There are some teeth that will heal with normal periodontal ligament. So we looked into this when I was in Kuwait. We were doing endodontic treatment on rabbits. That's not easy. I'm not an endodontist, but I had a good endodontist who did this for me. And we replanted teeth where we had taken out the periodontal ligament. And we saw massive ankylosis. Regardless of we left the periodontal ligament or took it out. And so don't do that. This resulted in the recommendation. The results of this study cast some doubt on whether the removal of the periodontal ligament in delayed replantation is necessary. We see that we have a few of them that heal even without ankylosis. Even after the extensive dry out time. So the risk of ankylosis rose with increasing length of dry time. Immature teeth have a lower risk of developing ankylosis, and some teeth may heal without ankylosis even after 60 minutes or more of dry time. And we concluded in this study that replantation should therefore always be considered in avulsed teeth, even after a long, dry storage extraoral period. So this is how research is moving us forward all the time. You should always be curious, follow up your patients for a long time, and ask questions to yourself. And this is where we are now when we're talking about clinical relevance. Previously it was monkeys, but due to the clinical relevance, it shows that the prompt replantation, we should continue to encourage avulsed permanent teeth to be replanted immediately as always the first alternative, even by telephone. Ask them to put back the tooth. Temporary storage in saliva should be encouraged if an avulsed permanent tooth cannot be replanted immediately, or a suitable storage medium such as milk or saline is not immediately available. And delay replantation after dry storage. Replantation should always be considered in avulsed teeth. Some teeth may heal without ankylosis even after a long dry time. Please do not remove the PDL any longer before you replant. The expected outcome is still ankylosis, but we can manage this, and that is my next lecture. Ankylosis results in bone replacements, and that's the best bone replacement material that you already have in place. And we'll talk about that in the next lecture. We still have need to evaluate storage media such as milk, saline, and other, and that's what we are aiming at. Please be member of the International Association of Dental Traumatology, because you will be exposed to accidents. It happens all the time, even at the breakfast table. Be also connected to the Dental Trauma Guide website, where you can find an interactive page that will guide you perfectly into what to do in the emergency situation. With the Dental Trauma Guide, you can connect yourself to the database in Copenhagen and get advice. And you can also, in the follow-up, be guided, as Dr. Paul mentioned. You can get the risks of different complications coming up. You can see, do I expect the risk of what? If you go to that webpage. So go in there and be member, and you get a free membership the rest of this year. So it's a wonderful tool. And take a photo of this. It's the code that they have been kind to give you. All participants of this meeting have the chance during the rest of this year to connect to the database in Copenhagen. Go in there, play with it. Even if you don't have a trauma patient, you can pretend you have and play with this tool. It's a wonderful tool. I thank you very much for your attention.